Okay, everyone, let's go ahead and get started. Again, my name is Jen. I am the founder of Sober Livers and excited for you all to be here tonight for our multidisciplinary care panel. We have some wonderful folks that I'll introduce here in just one moment, but first we're going to go through our agreements. So I'm going to share my screen. And please let me know if the right screen comes up, if you see the notes or if you see the actual agreement screen. And then I'm going to hold on 1 second. All right. Okay. How's that? Everybody seeing the right one?
It says the next slide in the,
Oh, it does. Okay.
yeah.
Thank you. Thank you. That's what I needed to know. I don't know why it always does that. There we go. That should be right. Is that right now? Okay.
You got
Thanks.
it.
All right, thank you. All right, so for the people that are coming in right now, if you could put in where you're from and what your diagnosis is, that would be great. And we'll talk about chat in just one moment. So here are our HOPE agreements. Participation is encouraged, but please inform us in the chat if you prefer to listen only. Feedback. Please share your opinions with empathy and compassion using I statements. For example, I had an MRI instead of an ultrasound because I had iron overload. Medical advice. Feedback is not medical advice. Consult your health provider before trying anything discussed here. Well, we know who our medical providers are for our panel, but if you are a medical provider and you are not one of the people on our panel, please just let us know so we can say hello. Confidentiality, ensure you are in a private space. Please use headphones if needed, and please do not share details about the group members outside of meetings using names. You can describe some situations, but please don't utilize names. And cameras, we do have the cameras on, or please turn your cameras on to help foster connection. And as I mentioned, we are recording, but we are recording we're recording the entire 90 minutes of this session, not just the first hour, because of our panel discussion. And so if you want anonymity when you're speaking, you can turn your camera off. But as I mentioned earlier, we do edit these recordings before we share them. So your face is never shown on any of our recordings. And so once again, anonymity, if you wish to remain anonymous, please use your first name and your screen name, and you can keep your camera off. And continued abstinence. While abstinence is not required to attend, please join our meeting sober. If you're under the influence, do not participate verbally or in chat, except to contact a facilitator for support. So if you are not sober and you're joining this meeting, you can definitely listen to this meeting, but we do have resources to help you. So we have several chat facilitators today, so you can step in and ask the question. But Kelly today is our main chat facilitator who will be sharing to me if you put any questions in chat so that we can ask the panel. So you can ask the panel on either chat or you can ask the panel by raising your hand. And so please use the hand raise function if you know how to use it. Otherwise, wave your hand so I make sure I see you. And the hand raise function is down in the bottom of your screen. Two remaining points. Politics. We are nonpartisan here. Our focus is on our shared experiences with alcohol use disorder, liver diseases, transplants, and related health issues. And finally, secularity. We are primarily secular, but we do welcome discussions on spirituality or religion as part of your recovery, as long as you're following our feedback guidelines. So please don't preach to anyone. We're here to learn from each other, offering compassion, empathy, and kindness. So please take what resonates you and leave the rest. All right. Okay. Just wanted to jump on here and see your faces, and then I'm going to introduce our guest today. And So today I'm so excited. First of all, thank you all for coming, and I am super excited about this today. We are going to share information about multidisciplinary care, but that does not mean that you can't ask questions that are outside of multidisciplinary care. Just know that any questions that asks, the providers are not going to provide you with medical advice. That needs to come from your doctor. They will talk in generalities. And so please, anything that they talk about, ensure that if you want to try something, that you talk to your doctor first. And so today we have, and I'm going in order of what I have on my screen here. We have Dr. Lamia Hawk. She's an MD and MPH hepatologist and addiction medicine specialist from Yale. We have Dr. Weinreeb, who is an MD, and he is the professor of psychiatry at University of Pennsylvania. He's the chief psychiatric consultant. We have Linda Coraluzzi, and she is going to be a doctor soon, so we're very excited for her. She runs the HEAL program, and she'll probably talk a little bit about that. That's a treatment program at Jefferson Health at Einstein. And then we have Dr. Gene M., and he's an MD, FAASLD. He can tell you what that means, the alphabet soup. And he is the director of Advanced Interdisciplinary Alcohol Liver Program and Treatment. It's called ADAPT. And he is at Columbia University. And last but not least, we have Dr. Suthat. Dr. Suthat, I am going to try Liang Punsicle. Is that close? I always call him Dr. Suthat. So he is the professor of medicine and biochemistry and molecular biology at the Division of Gastroenterology and Hepatology at the University of Indiana. So hello to all of you. Welcome, and so thankful that you were able to join us. This is June, the month of June 2025, and this program, our community, turned 1 year old this month. So this is a very special occasion for us. So thank you so much for joining. And with that said, how we're going to do this first is we're going to get an overview of what multidisciplinary care is from a hepatology perspective and then from a mental health perspective. So, Dr. M, could you start us off, please, and share about multidisciplinary care from both your standpoint from your hospital and also a general overview of multidisciplinary care?
Sure. Good evening, everybody. And thank you, Jen and organizers for the invitation to speak to you guys today. As a patient advocate, Jen, you are always surprising me about how remarkable and vibrant you are in terms of bringing a community together. And I think a testament to that is your ability to ask people to put things in the chat, and it just happens, and that was, and so I learned a lot actually about the audience for today. So hopefully myself and the other speakers can sort of tailor our message to make it insightful for you all. So a little bit about myself. I'm an assistant professor of medicine and a transplant hepatologist at Columbia. I was previously at Mount Sinai in New York for a number of years, but recently moved to become the director of the Alcohol-Associated Liver Disease Program. Enough about me. Let's talk about integration. All right. So what I think about when I think about integrated alcohol care, whether it's alcohol use disorder or alcohol-associated liver disease, I really think about a collaborative type of care model, which essentially means that there's significant interaction between providers coming from different areas of expertise to really synthesize tailored care plans that don't happen in sort of with tunnel vision, but in a collaborative way where where patients are the care is centered around the patient, for example. I saw in the chat a number of you have some experiences with liver transplantation, either on the waiting list or taking care of someone who is on the waiting list or who had a liver transplant. And so many of you are familiar with the concept of integrated care or multidisciplinary care because transplant is the model for transplant care throughout the country is pretty consistent because it's so complicated, both from the medical, psychosocial, and surgical side, that it forces us to be able, as healthcare providers and systems, to have to provide that level of care. Now, many of you probably are aware of this, but uh, that type of model has not traditionally been applied to the care of patients with alcohol problems, right? For a variety of reasons. But some of the things that come up to the top of my head are stigmatization, a lack of resources, and basically not a lot of buy-in from medical leadership about the importance of taking care of patients that have alcohol-related issues. But I'm happy to report that things are changing a lot. And my clinical program called ADAPT, which is an integrated alcohol-associated liver disease clinic, is one of a number of growing integrated clinics or care programs throughout the country that have really blossomed because there's a need to provide this type of integrated care, patient-centered care. For our patients, because the burden of alcohol-related problems in the world, but also in the United States, is only increasing. And so you'll probably hear from other speakers today that there is this need. We're trying, at least from in academic centers, to really lead this effort. And I think you'll hear from other providers that there are many different ways to provide integration of care. There is not one single model, although I must say that there are some very early models of this type of care in the hepatitis C world coming from University of North Carolina, Duke, I believe. But the current sort of trailblazers of this effort really starts with at the University of Michigan with providers there. So hats off to them, Jessica Mellinger and Scott Winder. So some other things that I just want to finish off with because I don't want to keep talking forever. But one unique aspect of integrated care, the result of it is that you get a significant efficient care that is patient-centered. Typically, integrated care allows for a single session, one visit, streamlined visits through the co-location of providers in one space, all seeing the patient rather than the patient going to different doctors, for example. There's consistency in the approach in this team model. So the patient's not hearing, well, he said this, she said that, and there's some, conflict or there's no communication that happens at all between providers. And there's realistic goal setting that often happens. And that can include, for some patients, more practical goals such as harm reduction rather than complete abstinence. Now, again, that depends on the patient, whether that's a realistic or reasonable goal or not. And that kind of approach usually doesn't occur in a non-specialized, non-alcohol specific care model, even in academic liver hospitals, right? This is usually because this sort of scenario comes about because there's a strong interest from all team members as part of the clinic to be able to provide this level of nuanced care. And so that's kind of just off the top of my head, Jen, my introduction and thoughts about what integrated alcohol care looks like. And I hope that may be able to jumpstart some ideas and discussions moving
Great.
forward.
Yeah, thanks, Jean, for the overview. Yeah, I think it's important to understand that this field is really changing and how we are working together now as partners with hepatologists and with mental health and with other disciplines as well. So that's something that I wanted to maybe touch on a little bit later is maybe some other disciplines that may be involved as well. But for the main part, we really are focusing today, right now, on the hepatology and mental health side of things. But to let everybody know, I will try to bring in other providers from other disciplines to share how their discipline relates to the liver and liver disease. So with that said, I want Linda to come on down. You're the next contestant on The Price is Right.
What do I win? What do I win? I'm going to apologize again very quickly because I changed internet services. So if I freeze up, just bear with me. My name is Linda Corluzzi. I am the founder of the HEAL program, which is a virtual alcohol treatment program at Jefferson Transplant Institute in Philadelphia, Pennsylvania. I see a couple of my patients on here, all my old patients. So I'm very happy to see everyone and very grateful to be asked to be here today. Jean, I really liked what you talked about this kind of upcoming, where people are becoming a little bit more less rigid about transplanting patients with alcohol use disorder. I just going to give you a short detail before I get into this multidisciplinary, because Dr. Weinreich is on here today, and he's the one that kind of introduced me to this population of people. So I've been in addictions world for a very long time. And by the time I got to Penn, I was just asked to kind of create this virtual treatment program for this special population of alcohol-related liver disease. And it kind of blew my mind that there was not a specialized treatment program for this population, and that I really didn't know that this population was out there, and that they were getting excluded, and they were not getting life-saving procedures, and they were being taken off wait lists because they had a drink, and all this crazy arbitrary nonsense. I was like, from my perspective, my mind was blown. So I was very passionate about taking that pilot program on. And so after leaving Penn, I brought that program to Jefferson, and I founded the HEAL program. So I am the patient advocate. I am the person on the multidisciplinary team that's educating my medical staff. When I got there, there was so many kind of crazy ideas. On one end, they were saying, yes, I know it's a disease. I know it's alcohol use disorder. And then on the other side of the mouth, it's like, we need to take them off the wait list because they had a drink. And I'm like, wait, what is happening right now? So they gave me a lot of strength and power on that team to create a criteria that was very simple for the patients. Because we need to transplant and treat the alcohol use, not just, I think you might relapse, so you're going to be a no. So I'm the person that sits next to the bed and assesses the patient on their readiness and willingness to change. And do they have insight that alcohol is really causing a problem in their life? And if they can verbalize that to me and they're willing to come to the HEAL program, they're going. We're getting them transplanted. We're getting them waitlisted, and I'm going to treat them. I am actually in the post-clinic team. So my office is in there. It's quiet. It's got a big comfy couch, and they can come in and they can just sit. I'm the person that's going to walk you through transplant. I have prepared many people for evaluation. I prepared many people to go through the transplant process that maybe would never otherwise have been candidates. So I feel very proud about that. And they're doing phenomenal in post-transplant. So what if we just would have left them alone and said, yeah, you're not a candidate? These people are thriving. We have an alumni group that they come to monthly, that the longest out are patients from the Penn pilot program. So the furthest out is 4 years. So it's beautiful to watch somebody that has literally 2 months out from transplant and are now 4 years out. So I love that. So I am there in the clinic. The patients know I'm in the clinic. They get discharged from the program. They're in our clinic for a whole year. So when all the dust settles and everybody goes back to the work and social supports are doing their life and they're no longer taking care and clinic appointments become smaller and smaller and smaller, I'm here and I hold you and I walk you through all the way through your year in liver transplant. And I absolutely feel very rewarding. It's very rewarding to watch people that the team itself was like, this is the highest risk patient I've ever seen. Linda, are you out of your mind? You're going to list this person? And I say, yes, I am. Because I'm a big cheerleader for the underdog for sure. So that's a little bit about the HEAL program. We are now just 2 years and we've graduated 80 people from the program. And we've 8 people have went on to liver transplant. Some people have been clinically, medically stable and not needing a liver transplant. And that's been lovely to watch as well. I mean, if you don't need a liver transplant, let's not go through it, right? So that's the multidisciplinary team has been open-minded. They understand the criteria. They understand the boundaries of like, you know, being more open-minded to delivering a treatment program virtually in the comforts of these patients' own homes after transplant, that they can get some education. A lot of people have never even been to treatment. A lot of our patients arrive into the hospital already still drinking. And so this is a whole new world. They wake up with a new liver and what do I do now? We've removed their best friend from them. They're no longer, you know, supporting and drinking. And I think that I'm hoping that from the Penn program that we did, and there's a paper published about that, to Jefferson's program, that a paper is about to be published for that, that we can implement this virtual treatment program in all liver centers. I am a licensed clinical alcohol and drug counselor. Apparently I'm a rarity, you know, in terms of my license, but I'm here and I'm willing to support all the patients, and thank you for listening.
Thanks, Linda. Thank you so much. I appreciate it. Yeah, I think exactly what you're saying is true. And I'm so glad that you were there to help the patients through, even if they come in, you know, saying, okay, I just had a drink, you know, 2 days ago, and you go, that's okay. Let's see what do you want to do now? Right. It's here you are. What do we do now? So thank you very much for sharing. And thank you for sharing the aftercare post-transplant. And so I know we have a lot of transplant folks on here. And I just also want to mention, because I do know that she also has an alumni program too, where the alumni all meet. And so past 1 year, she still has people that are getting together and supporting each other. So thank you for that. Okay, let's see. Dr. Suthat, would you like to join us and share a little bit about Indiana University and what you guys do over there?
I think what Dr. Im just said earlier, I think we have a kind of a similar now in terms of having, you know, addiction specialists kind of co-located in the service. Again, I think several of you just mentioned, I think for alcohol-associated liver disease, I think this is like a 2 diseases in one patient. And then as Dr. He mentioned earlier, I think, you know, the way we care for our patients, I think, you know, we train as a hepatologist and we start to learn from our colleagues, but having a specialist who kind of have expertise to treat very specific on alcohol use disorder, I think that's is very, very important. Now, I also practice over at the VA as well. I think sometimes I think I would like to bring up the role of the pharmacist. I think you know, we also have a pharmacist in our liver clinic that has been very helpful. You know, in terms of tracking medication we prescribe and also refills to make sure that our patients are in compliance with the medication that we gave them. I think that's also another piece that I think we should also think of them when we do care for our patients with ALD. Gonna be short. I'm gonna stop here and then looking forward to more questions from our patient that on this panel.
Thank you. Thank you so much, Dr. Suthat. And let's move back over to mental health. And I'm glad you were able to make it, Dr. Weinreeb, and so excited to have you back. Let me spotlight you here. So, hi, Doctor. And I want everybody to know that did not come to our first meeting last June. He was our first speaker that we had, and we were so excited to have him join us as our first speaker, and so excited that we full circled back, and now he's back with us again. So thank you so much, Dr. Weinreeb.
Thank you, Jen. I really want to echo, I think, what Suthat said and Jean and Linda about the importance and the significance of working as a team. And Jen, thank you for organizing this with Beth. It's amazing what you do. I thought it might be interesting to have a little bit of a historical perspective, because I've reached that age where I can do that kind of thing. And I'll tell you the story of liver transplant and alcohol use disorder from my perspective, which started in about 1993. So you guys do the math. But I came to Penn to do an addictions research and clinical care fellowship through the VA and through the University of Pennsylvania in 1991. And it was a 2-year fellowship. And at the end of 2 years, we were expected to write a grant that would allow us to become clinician scientist development awardees, if you will, so that we could become independent clinician scientists. Not a lot of physicians go through this training. I think at the time from the NIH, only 4% of all the grant awards were being awarded to physicians, and the rest were mostly non-physicians, which is fine. But it just goes to show that it's not an easy thing to train a doctor to do this because we're busy in lots and lots of different ways. And it requires a lot of support from other people, mainly administrators and mentors who are willing to let us do whatever it is we want to do. And what happened is that I was getting close to that time where I had to write a grant, and I was very interested in the treatment of alcohol use disorders. At the time, we were just starting to do pharmacologic treatments for the first time, studies, and the drug that we were studying for the first time is called naltrexone, Revia. You may have heard of it. And, we were seeing some amazing things with it. We were seeing people who couldn't stop drinking once they got on this medication. If they did drink, they were able to stop after just a couple of drinks. It just didn't have the same appeal to them anymore. And so we thought, we're onto something. And I was thinking, how am I going to put this in a grant? What would I want to do? What kind of population would I be interested in? And I had lots of ideas. But then I got a phone call from one of my best friends whose dad was a teacher of mine in high school. And his dad had alcohol use disorder, and he'd stopped drinking at that point. But he needed a liver transplant, and they were evaluating him at the University of Pittsburgh. And my friend said to me, do you know anything about this? Can you help us make this decision? And I said, not a thing. Never even heard of it. Let me go to the library. So I go to the library and I look up whatever it is there is on this stuff. And for the most part, I see 2 kinds of articles. The majority of the articles were surgical outcomes and hepatology outcomes, which were very positive. Basically, they were saying that, these folks do very well medically, once they get the transplant, and they don't have a lot of other complicating factors medically. And so they do well. And there were a number of people who were in support of doing this kind of work with people with alcohol use disorders then. And there were a lot more that were not. And that was the bulk of the papers. It was a lot of ethics back and forth. Is this something we should be doing? Does this take away from other people? All of it. And, I got to thinking about this. And one of my observations was that there was not one single paper written about the most the most frequently transplanted organ being liver. For what reason was alcohol related reasons. That was the number one reason for liver transplant in the country. There wasn't one paper on the treatment of alcohol use disorder. So that was what I did. I wrote the first grant in that area and studied whether or not that new drug, naltrexone, would be helpful, along with this fancy counseling called motivational interviewing, which nowadays is just standard of practice. And what I learned was that I didn't know what I was doing. And we couldn't recruit patients because, let's face it, what patient who just got a liver transplant wants to take a drug that they don't feel they need that has a risk of hurting their liver? So I couldn't argue with them. They weren't wrong. The truth is that it's actually very safe to take naltrexone in liver disease and any kind of problem, because it doesn't really harm the liver in low doses. And not just that, but it's never caused liver failure, and you can stop it and everything kind of gets better. So I understood why people didn't want it, but what I didn't understand was the population. And so I had very, very good mentors who helped me to develop other studies that looked at the population in depth, primarily from their perspective. What kind of things would you like help with? What kind of things would you as a patient need to go through this process? And that became the focus of my next research grant and my next study. And I didn't have any medication involved, which was okay. Nobody really at that point was interested or needed it. But things have really changed over the years. And one of the things that has changed is that instead of having a long period of abstinence prior to being eligible for a liver transplant, in part as a result of what happened to people during COVID, where their drinking escalated to the point where very young people were now needing liver transplantation, people in their 30s with cirrhosis. And the survival rate without a liver transplant for their condition, alcohol-associated hepatitis, was very low. And so everybody said, well, we have to transplant them. And everybody agreed that we should. But how are we going to deal with the fact that they've never even thought about the fact that they might have an alcohol problem? And how will they, stay healthy and stay sober and this and that? And so I was able to approach the people that I worked with and say, yeah, I have an idea. I think we could start a program just for them. It's something that I've been thinking about for a long time, but I've never really been able to do it for a lot of reasons. So maybe we could do that. And so I approached the addiction treatment program there at Penn, and was fortunate enough to meet Linda, who was like a godsend, who just took this on with great energy and gusto and excitement and optimism. And I couldn't have asked for a better partner in that. I really couldn't. And Linda turned this into a success. And at this point, I think we had run 200 patients through this program. And so one part of our integrated alcohol treatment program is, and this is very unique, I think, Linda's program and our program are one of only a few that offer alcohol use disorder treatment only for the people with alcohol use disorder and liver disease. And what I've learned from them is that they really support each other, that, the counselors are invaluable. Their help is absolutely necessary. But what really keeps them together, and I think what makes it interesting to them and actually fun, a lot of people want to go back to these to these groups because they're having a good time in their treatment and they're supporting each other, which is something that AA has been aware of for 70 years or something. So so we modeled it like that, and people did well and they enjoyed it. And yes, they formed an alumni group with Linda's support. And we at the same time started to see some great interest from the hepatology side. And that was something that I was trying to do my whole career. I was going to liver meetings, surgical meetings, hepatology meetings, and asked to speak to them about, how do you work with patients like this? What do you say to them? What do you not say to them? I think a lot of the perspective then from the doctors was, like, just say no, just stop. Why are you doing this to yourself? Don't you realize you're going to die? And, that's all those things are true, but that doesn't help you stop drinking at all. And, they didn't really understand what it meant for people to kind of go through different phases of acceptance and understanding and development of their own ideas and plans to get better. And so we were doing that. And the hepatologists were excited about that. And we had a great couple of hepatologists who decided they were going to do the same thing we were doing together with us, writing a grant and having a co-located clinic. So seeing patients together at the same time. So there's two branches to the treatments that we offer for folks. One is the 12 weeks group and individual counseling. And that's based on the work that Linda did. And then the other one is treatment that takes place in the hepatology clinic, in the liver clinic, with us in psychiatry and with them in hepatology, and also social work and nursing. And we huddle. So every time we meet with a patient, we get together and talk about it. And then the next specialist goes in. And so they're all kept up on it. And then once a week, we sit down and we talk about every single patient we've seen, how they're doing, what more can we do to help them? Have we not heard from them in a while? And so they're getting really, really great care. And they didn't used to. It used to be very difficult. I think one of the most frustrating things about my job for many years was to do an evaluation for liver transplant patients. And as a psychiatrist, I wanted to see, okay, if there were psychiatric drug or alcohol problems, how could we treat those problems so that patients could be healthy and be eligible for a transplant and hopefully stay healthy after the transplant. That was my role. But I'd refer people out to the community and they didn't connect, and nobody wanted to go near them because they were too complicated, and patients began to feel like they didn't fit in. And so this type of setting that we're seeing now all around the country is the first time in my career that I've seen the two fields come together. That's liver disease and psychiatry, to treat the same problem that has always been in need of that sort of approach. And I think it's working really well. And I think patients see that and feel that. And I was ready to retire a couple of years ago, but how was I going to do that when this stuff was starting to build up? I'm like, oh, no. This is too good, too exciting. Been waiting my whole life for this. Let's keep going. And so we have. And it's just great to see people around the country getting into this. And the amazing approach that liver specialists take that we didn't. We learn from each other. And I think together we are much more effective than we ever were alone. And so
Hey, Bob, I'm gonna have you kind of I know, but Bob and I will get in conversations for hours if we could. But yeah, if you could wrap it up, we'll continue this discussion because we have a panel discussion too. But I want to make sure Lamia gets to say hi just in case she needs to leave early and we want to give her some space. But thank you for I cannot tell you how much this man has really changed the face of how patients are treated. So we are so blessed to have him here today. And so ask if you have questions. I know he may have answers and he's got the historical knowledge. He's better than an elephant. So so thank you so much, Bob. I appreciate you. All right. Hi, Lamia. Nice to see you. So this is Dr. Hawk. I'm going to let her talk to you for just a little bit here too before we go into some questions. So let me spotlight her, and hi there.
Hi there. It's great to be here. Thank you so much for the opportunity to join. It's really a privilege to meet with all of you, and this is such an inspiring group that Jen has created. So thank you for the opportunity. So I guess I'll just briefly share my background. I'm an assistant professor of medicine at Yale School of Medicine. I have training in both addiction medicine and hepatology and liver transplant. And so I've been fortunate to be able to kind of wear different hats and sort of see different perspectives as I went through my training, and hopefully use those both in my clinical practice as well as research. At the time that I was sort of thinking about starting on this path, I remember that I felt similarly to Dr. Weinreeb, where I felt like there really wasn't that much literature and there wasn't that much clinically, at least where I was training, that was going on. Although I did read the papers that you wrote and which were some of the few that were out there, and just felt like I really needed to have as robust a skill set as possible to be able to sort of address this for the specialized population. So I figured going through the clinical training would be really helpful. And I think it was actually one of the best years of training that I had. So I'm really glad that I was able to do the addiction medicine training. And kind of moving forward, I was able to apply that to sort of the patients I would see on the hepatology side and in transplant. And now fast forward as a junior faculty, my clinical program is also an integrated program, though was a little bit different, I think, in how it started. It was just me initially. And then over time, of course, we have been so grateful to have involvement of our behavioral health colleagues. So, my background is in addiction medicine, though we do learn some motivational interviewing, where thankfully at our program, actually our addiction psychiatry and addiction medicine programs do training together. So I was fortunate to be able to kind of sit in on their didactics and learn from them. But of course, I'm not a psychiatrist, nor am I a psychotherapist or a counselor or anything like that by training. And so having that, having colleagues, in behavioral health to collaborate with has been really, really instrumental. And so our clinic, the way it is now, our transplant and sort of hepatology center has many different sub-programs, and my sub-program is within sort of the general hepatology clinic. The reason being that I'm able to see anybody. So I see people who are at the earliest stages of sort of the alcohol-associated liver disease all the way through after their liver transplant. And I think that's just a logistical thing where like anybody can come to me, which is nice, people from the liver cancer program, wherever. And so I basically kind of do a hepatology visit just like I would if I was like a usual hepatologist. And then I'm also able to address kind of any addiction related issues that may come up. And so I'm able to kind of prescribe medications. I agree with everything that's been said about the medications. They're so important as a tool if it's in line with the patient's preferences. And then of course, I have my behavioral health colleagues, so we're fortunate to have a clinical psychologist as well as a social worker who are both able to meet with patients if they feel like that's something that they're interested in. I think one of the biggest challenges that many of our patients have is to just access high quality mental health, care and therapy in a timely fashion. Individuals who have sort of background in alcohol use disorder treatment, as well as medical complexity, like others have said, it can be hard to find. And so I think that when a patient already is dealing with so much medically and likely a lot, just from sort of their life and psychosocial perspective, the burden of having to then call your insurance and go through 10 different people to try to find a good fit is a lot. And so it's been great that when patients are checking out, I can say, if you want to meet with this person, they will book you when you are, leaving our clinic. And that's been working pretty well for people. So I'll stop there for the sake of time, but thank you again for the privilege of being able to meet all of you.
Thank you. Thank you, Dr. Hawk. Oh, that was so great. And I'm so glad that you guys have this program now, and that you're like you can do a lot with with patients, regardless of whether or not you are working with them on their addiction, but you can also ensure that they get to behavioral health. You'll be able to evaluate them for what their needs are. And I think that that's such a specialty that you have with being an addiction physician. And I do know that that's something that a lot of other hepatologists are looking into doing now. So you are paving a path for others. So thank you for being here. Okay, so we are going to take some time to answer questions. And so if you have any questions right now, please raise your hand. And if you have a particular provider you would like to address it to, just say, or otherwise just ask the question and I'll let them free for all and answer the questions that you may have. Anyone? Don't be shy.
I have one for Linda. Linda, you must have been on my side a year ago because I came into Jefferson and I came in like a train wreck. And it's been 1 year. We were just discussing this our last meeting. Jefferson was absolutely wonderful, and I'm a Jeffer for life. We kind of joke about that now. So I appreciate everything you've done and what you're doing. I think it's a wonderful thing. If you had any second thoughts about me, I hope they went out the window at this point because I've been sober ever since, and I'm fully involved with trying to get more involved. Uh, After the transplant, it's been a year, so here I am. I really appreciate everything you do. Thank you.
See, that's a perfect example, right? You just said you came in as a train wreck and you are still holding your own. So we can't really judge it based on what was happening prior. I'm very much a solution focused therapist. So I look at what we're going to do now moving forward. If we gather everything from the past and make judgments based on that in the world of addiction, nobody would be transplanted.
Yeah,
I wouldn't even
yeah.
be transplanted, trust me. So I'm glad to see that things are working well for you.
Thank you. Thank you.
Yeah. Frank has become a regular too here, Linda. We love having him. He's really, he's a great participant in sharing, and I really think he really helps move our group and helps with the engagement to let people know it's okay to talk. And Paula's another
Yeah.
one that we love. Hi,
Yeah.
Paula. How
Thanks,
are
Jen.
you? You're welcome, Frank. Hi, Paula. How are you doing? You're on mute, so go ahead and unmute yourself and
I
go right.
asked you the question. I wasn't sure if it's appropriate for me to ask this group. So I'm just going to ask the question. I think I know the answer, but I kind of want to hear it. So I just had like a simple little virus thing, and I called urgent care, and urgent care wouldn't take me because I'm post liver transplant. Can somebody, is it because I had a liver transplant and they don't know how to help me? And that's why they always refer me to like ER? I don't know if that somebody can answer that or not.
I could take that. It's a very good question. I think it depends on the level of comfort of the providers in an urgent care, whether they feel comfortable enough to be able to give medical advice. You know, we talk a lot about stigma around indications for liver transplant and alcohol, but in a way, medically, someone who is a transplant recipient, there's a stigma in the sense that you're complicated, right? You've been through a lot. You're medically, surgically complicated, and you're on immunosuppression. And I think that, rightfully scares some providers who are really inexperienced with that. So it probably comes from a place of, being erring on the side of caution rather than them not wanting to take care of you, more just they're concerned that a recommendation as simple as an antibiotic for a cold, for example, may interact with your transplant medications and lead you down the path of complications like rejection or something like that. So that's probably where that's coming from.
Okay, thank you very much. I really appreciate it.
Hey,
So I guess I'll just go to ER each time.
Yeah, it sounds. I mean that sounds like it's really complicated, but I understand where they're coming from. Because they don't want to make you sick. So I know the ER is a pain. So, good luck. I hope you don't do that soon.
Yeah, I was gonna say my gynecologist didn't really want to treat me anymore for a cyst because she said I was post-transplant. I was like, okay. So I went to Piedmont.
Yeah, that's wow. I don't
Yeah.
know. anybody has a response to that, but sorry about that, Caroline. It's good to see you though. Glad you're
I went
here.
to Piedmont. Piedmont's the best.
I know. Beth knows Piedmont pretty well. Hey, Beth, we love you too. How are you doing?
Hey. Hi, everybody. So good to see you again, Linda, Bob. I have a question because I talk to a lot of transplant centers. And the biggest part that I have seen for creating a multidisciplinary care center is on the mental health side. I constantly ask, do you know an addiction counselor that I can hire? And things like that. And Linda, you know this because of conversations we had, when we were at the liver meeting. But my question is, do y'all see more people on the entry level side to the profession wanting to focus on alcohol related liver disease, or are we still trying to convince them, to go into the field? Anyone?
Anyone?
I could try and take it. I think we're still trying to convince people, to be honest.
Yeah.
Yeah, I really do. I think there are so few of us who do this, and people are so intimidated by the complexity of the problems. When I say people, I mean other psychiatrists, other mental health professionals. They're afraid, but really what they're afraid of is only their fear. They can always contact any of the providers that work with a transplant patient for questions they might have about things that they might want to do to help their patients. So they need not shy away, because I think all of us see that as part of our role, is to the wider community, that if somebody is seeing a psychiatrist who doesn't know how to prescribe a medicine, to a patient, is afraid they're going to hurt them, my patients all know that they can tell that person to call me and we'll talk about it. So that's, I think, starting. I will say that, I run a fellowship for a field called Consultation Liaison Psychiatry, which is just complex medical care and psychiatric care together. And my fellows, more and more of them are actually getting more interested in transplant. So I just recruited another one. So
Yeah.
we're seeing
I
it
mean,
a little bit.
I want to say that too. I had I'm not sure residency versus fellow in terms of like positions, but they both were interested in addiction, very young in their fellowships, and they spent a month with me, two different ones, wanting to know. I think it's really based on the role of the hepatologist in what their view is of it. I think the older generation role, if they are supportive of the addiction, that's what's teaching these younger people. And then we have somebody like me on the team who's like evaluating. They come in and be like, they seem like they really had good insight. And I said, no, they didn't at all. And they go, what? Because we have a different view, right? But it is nice to have these younger fellow and residents coming and wanting to ask me lots of questions about addiction. So I think they're starting to come, maybe.
well, I
Dr.
hope
Hawk,
so, because
I saw Dr. Hawk wanted to make a comment on this too, and so she went into this addiction medicine. Do you want to respond to Linda real quick, or?
Yeah, definitely. Yeah, I think that I agree. I think that at least from the alcohol-associated liver disease hat, if you will, it really does take the buy-in of hepatology and of sort of medical practitioners to be able to form these partnerships. I think in general, I guess there's definitely been a movement in the right direction. As Dr. Weinreib was mentioning, we see more and more hepatologists have, especially, newer ones, have interest in this area. I think on the addiction medicine side, it's very interesting because I feel like alcohol has also kind of been neglected more, relative to like opioids and just with the overdose crisis. And so I think that is also changing with what we're seeing, in the hospitals with more and more patients with, severe alcohol-associated liver disease. There's more interest, and I think initiatives on that side too. So I think it's changing, but I agree that it's going to take a lot more advocacy to really build capacity.
well, I'm also noticing that, especially locally, in Atlanta, at Piedmont, and both Emory, that as some of the older doctors are retiring, the new ones are coming in, they're a little bit more progressive towards the subject and things like that. So, it could just be trying to you know, I don't want to say circle through or something like that, but I'll just say it. That's what I mean. But yeah, so good. I like that information because that's the missing piece in most transplant centers.
She wasn't talking about you, Bob. Don't worry.
I think something really important that what really helps younger doctors is your stories. You know, for you to explain what you've been through, where you're going, and why puts a face and a heart to something that they previously only read about and didn't really understand. And they have to understand that everybody deserves a second chance, and everybody can do well with the right, you know, with just the right support. But it helps them when they meet somebody, an actual person who's been through it.
Tell me when and
helps.
where. Tell me when and where,
Yeah.
Bob. You know, but I made a comment the other day about second chances. I mean, you know, we view people that have been incarcerated, you know, they're talking about their second chance and stuff like that. You know, I would love it for one day for it to be, you know, just as simple as that in people's heads. But go ahead. I'm shut up, Jen. So,
Okay, so Beth, thank you. No, thank you.
Jen, can I ask you a question?
Well, actually, hold on 1 second. We have somebody who doesn't know how to raise their hand yet, so I want to have her be able to ask a question. So Jessica, if you can unmute yourself, we'll be able to see you. There you are. Hi, Jess.
Hi. Probably gonna cry. Thanks for having me. So this is all like really new for me. I am scared to death. On top of what's probably already my irrational fear of death. So I guess my question is, when they put you on the moderate priority list, like he really didn't get into like how extensive that is or like how quickly the process would work. And I was wondering if anybody had information on that for me. And he's a great doctor. I'm going to UNC Chapel Hill in North Carolina. He's just touching on what was said a moment ago. He's very angry with my doctor here for telling me basically that nobody would entertain me because I've been sobered out for 4 months. Lost everything, my marriage, good job, just everything, you know, the classic cliche of jails, institutions, and death. So like, I just want to know, like, I'm scared.
So Jess, is your question if you're on a moderate list, and maybe one of the doctors here or can explain that.
Yeah, like,
are you wondering like what you need to do at this
like,
point?
I mean, you know, it's increased my protein and obviously abstained. So I was sober for like 100 days. Last time I relapsed after 100 days, my numbers were getting better and like I couldn't give anybody a reason why. And having a little bit of a psychology background myself, I sat there and I just thought about it and I thought about it. And I think just somewhere in the back of my mind that I rationalized since my numbers were getting better that I could take that drink. Which clearly it's a do or die situation for me. And that's, like I said, I already have an irrational fear of death. So this is not an option for me to ever take a sip again.
hey, Jess, you are right. My best advice to you is that you're where you need to be. You need a buddy. You need somebody that's been through the process. Lindsay is in North Carolina, but she has not had a transplant. Yeah. But she did not get a transplant, but she might be familiar with that program. But you know, reach out, find a buddy from this group. So yeah. Oh, that's right, Nicole. You were there too.
Yeah, Nicole.
She's at Duke. I'm at UNC. Yeah, I'm gonna send you a message, Jess, with my email.
Okay, thank you.
Yeah, and we do have a buddy program, Jess, too. I don't know if you saw that on the welcome letter. I'm not sure. Did you? And so that buddy program too, but Lindsay is a great resource. She's wonderful. And so is Nicole.
Yeah, I got a chance to get through some of it. So I don't know like if Nicole is familiar with it, but we have a hospital around here called Cape Fear Valley, and it's known as Death Valley. So I've just been, being proactive with what, my doctor asked me to do and what the counselor asked me to do, and just dealing with them is insane. It's annoying. It's frustrating. And he's trying to make it convenient for me so I don't have to drive to Chapel Hill. But like at this point, I'd rather make the hour and a half drive and just be done.
Well, do what's best for you. Yeah, do what's best for you. Be the best advocate for yourself. And if you're not comfortable where you are, definitely I would make the trip. But I'm curious what that if one of the doctors have any advice for her in this process and where she's at this point in time. Or encouragement.
Yeah, hi. Thank you so much for sharing that. I think I'll just start by just acknowledging that this is having any sort of severe or chronic illness can be very difficult. And so, I think your concerns and fears, you're probably not the only one who's had that.
Yeah.
And so I think that it's great that you're reaching out for help. I think that's so important. I think a buddy system sounds wonderful, like some have suggested, and I think that can really be helpful. It sounds like, you have a team that you've been working well with. And so I think that sometimes it can just be very hard, from my own experience, for patients to kind of understand the system, understand what's going on, feel like they're getting all the information that they need, or that it's presented in a way that is clear. And so I think continuing to ask questions if anything doesn't make sense or if something needs to sort of be clarified. I agree that patients need to advocate and to sort of have their team and whether it's peers or other providers to help kind of advocate. And yeah, I think that you're doing the right things. I think just making sure that you're continuing to check in and ask questions and make sure that everything makes sense to you and that you feel comfortable. But I thank you for sharing that, and I think that it sounds like you're headed in the right direction.
Thanks.
All right. Thank you, Jess. And yeah, and Lindsay will reach out to you if she hasn't already put it in chat. So check in chat, and I'm sure she's given you.
Thank you.
She'll help you out.
Thank you, guys.
Great. Thank you, Jess. Nice to meet you.
Nice.
Hey, Mark.
Hey, how you doing?
Good. So Mark is also one of our advisors. I just want to mention real quick before you start, because I didn't recognize our advisors that are here too. Lindsay is our Silver Livers intern and also bouncer. Mark is an advisor that we have that is located in Massachusetts, and he has not had a transplant. He has a recompensated liver. And then we have Kelly, and thank you, Kelly, for being here. And she's on the transplant list. So go ahead, Mark. Sorry to interrupt a little bit there, but.
Yeah, so I have like a two-part question. So I'll let you guys fight it out to see who wants to answer them. But the first part of my question is, I'm a big advocate of this whole concept of integrated teams. So long in medicine, and I've been around it my entire life, is a perfect example of one hand not knowing what the other hand's doing. And the fact that this is happening where multidisciplinary facets of patient care are, kind of coming together is fantastic. With specifics to, the topic at hand, alcohol-related liver disease, as everybody on this call knows, neurology plays a huge part in patient care, not only before you get a transplant, but after you get a transplant. And even if you don't get a transplant, the ramifications of the damage that's been done from a neurological standpoint can be significant. And I'm just curious, you know, in your view as, you know, the panel here tonight, you know, do you see neurology playing a role all the way through this or partially through it? And it's definitely, in my opinion, going to be part of the long-term care plan. So just a question about that, and then I'll give you my other question, and then I think I'm not sure who mentioned this about coming up with an individual patient care plan, but the statement really intrigued me in terms of are you actually referring to patients participating and setting goals and that kind of thing? And I'm not sure if it was Dr. M may have brought this up, kind of where you stand on that. And with that, I'll let you guys answer.
Dr. Suthat, you haven't answered a question yet. Would you like to respond?
Yeah, first of all, I'm not quite sure in terms of when you talk about neurological problems that you have. Normally when I see patients with end-stage liver disease before transplant, you know, sometimes the problems with like numbness or something that quite common in patients with cirrhosis. That's normally what I see. But when you talk about neurologist or neurological service with you all the way, can you share a bit more about
Yeah, and I'll have my my partners in crime on this call contribute to this as well. And again, I'll just throw out the initial seeds here. One is peripheral neuropathy, which is engaging to start with and then downright, you know, like a biological twin as you go along. The other key issue, and it kind of happens, and I haven't been able to find anything in the literature that tells me where specifically this begins to manifest itself, but the whole concept of your brain relearning the whole balance function. And, you know, it starts with just, you know, being ambulatory, but then, you know, there are a lot of other things that come into play. And so from a neurological standpoint, balance is a huge issue for any of us that have suffered it, you know, liver disease. And I don't know if it's specific to alcohol or not, because usually the first time you get drunk, your balance isn't too good. And if you do it enough, it's not good forever. So that's why I brought in the whole neurologist aspect.
Yeah, I think alcohol certainly play a role in specific types of neurological problems. I mean, you know, vitamin deficiency again. I think peripheral neuropathy we see quite a bit. Maybe not specific to alcohol-associated cirrhosis patient before transplant, but also other, you know, the liver disease from other causes as well. I sometimes give specific medication for neuropathy. You know, not necessarily refer patient. I think this may be like a provider preference. I don't know, Jean can chime in as well, but certainly in cases that may be difficult to manage, we certainly may, you know, send patients for neurology consultation. But when you talk about when, you know, neurology service with you all the way, I think that's maybe site specific and, you know, how severe the patient. I don't know any other of my colleagues can chime in on this, because I think this may be very specific type of presentation. Jean, you have anything to add?
Yeah, I'll add that I think an integrated clinic model can be very helpful to have the hepatologist be the sort of first line provider to help address this, because like Suthat was saying, you know, if we have collaborators in the care of a patient who can spend more time and expertise talking about, let's say, medications for alcohol use disorder or types of psychosocial therapies, motivational interviewing, then that frees my time up to be able to, you know, focus more on, you know, things like peripheral neuropathy and treatment. I think we often are first line providers as hepatologists. But I think something, Mark, that you're alluding to is sometimes you have effects that may be related to cirrhosis, or if you don't have cirrhosis, some subtle signs of imbalance or disequilibrium, for example, that are likely related to what we call central nervous system effects of alcohol, sort of frying the nerves a little bit.
Exactly.
You know? And sometimes you just have to ask the patient, like there's certain questions that I ask, even though, unprompted, because my hit rate of yes to that question is so high that I just ask it. So for example, how are you sleeping? As a hepatologist, it feels a little weird to ask that question, but it's always been a problem, in terms of insomnia for patients because they have untreated anxiety or they've recently stopped drinking. Or how's your balance been? Can you get out of that chair easily, or has something changed? And you get a lot of information about frailty, or often, a lack of balance, and that often is a reflection of basically alcohol effects on the central nervous system, primarily the balance centers of the brain, like the cerebellum, for example, right? And so rather than chalking it up to, oh, maybe they're intoxicated or whatever, this is likely, these subtle signs are actually very real. And, the way we don't necessarily integrate neurology care, may be something that we should look into, perhaps, Mark. But usually, and I think Sutat would agree with this, we have sort of a handful of neurologists who are our go-to people, who are really experts and have a lot of experience in alcohol-related neuropathies, and then they become our go-to collaborators. But I think perhaps and this depends on where you practice, the medical necessity of neuropathies being super high hasn't really reached that level where we, co-locate neurologists. But maybe in the future, that's something that we need to do. So thanks for bringing that up.
Yeah, I have the same problem that that Mark has with neuropathy, and it's come up a lot in our meetings. Just to let you guys know, it is an important question to ask, and because they may not even realize that it was their liver or the alcohol that is causing their balance issues and their neuropathy, and may not know what that is at all. So, thank you very much for bringing that up, Mark. Hey, Virginia, I see your hand up. How are you?
Hello. Doing real well, thank you. I have just a quick question, and that has to do with I'm sorry, can you hear me?
Yeah.
Yes.
Okay. I just wanted to know about the importance of having like a nutritionist or dietitian. My situation is that I've been diagnosed with cirrhosis, but my GI doctor said, well, you can't see a hepatologist yet. And, but I really think I need to do something about, to try to be the best I can be. And at this point, I'm not under any kind of treatment. And I thought, well, nutrition is a treatment. I mean, does anyone have any experience with that or recommendations? Or am I just thinking too hard about it?
Linda, would you like to answer that question? I don't know if you've gotten involved with the diet or any of our other doctors. I know I've been trying to see a dietitian for a long time, and there's a very big lack of dietitians out there. I can tell you that. Not as bad as addiction counselors, but Nancy, what do you want to say? Go ahead.
I would love to get involved with that. I'm driving.
Okay, go ahead.
I can't change my name because that was for another group, and I'm driving.
That's okay.
Okay, well, first on the neuropathy, I'll touch on that in a minute, but the diet, I have seen people just totally reverse their F3 to F0 for diet. Clean, healthy eating, avoid the boxes, the cans, the ingredients you can't pronounce. A diet is everything. Diet and exercise. As long as you don't have cirrhosis yet, you can turn that baby around with diet and exercise. And that's my thing. And as far as the neuropathy goes, you were saying a lot of people don't associate it with their liver. When I first started having neuropathy, She had no idea I had liver disease. She just was giving me gabapentin from pins and needles in my feet. So even some of the experts don't know. Just surprised.
Yeah, and can I repeat what you're saying because you're a little hard to hear. So are you saying
I'm
that
sorry.
that's okay. Are you saying a lot of doctors don't realize that neuropathy is actually a thing with the liver? Is that what you're saying?
Exactly, yes. Well, they're not liver specialists, but they're treating something that they don't even know what they're treating.
Okay.
They're just masking the problem. That was my experience.
Yeah.
I don't know if anyone else. And I did not need a neurologist post-transplant until recently, until this last year.
So not post, but pre-transplant you did.
I did not pre-transplant. My primary care doctor and my GI doctor for treating my neuropathy.
Okay.
But post-transplant, I had nerve damage from the actual surgery, which has caused pinched nerves in my neck and other problems. So now I need a neurologist.
Okay,
And,
gotcha.
And gabapentin for that too.
Yeah, gabapentin has been I've heard a lot of people on gabapentin for neuropathy. I'm on Lyrica for neuropathy. But once again, talk to your doctors. So, hey Nicole, you got a question or a comment?
Yeah, I just have a question, sort of, about the neuropathy. Well, has anyone seen? I have had myopathy as well as neuropathy and a lot of muscle degeneration, and I've had rhabdo. Has there been any findings of links with the liver and muscle issues and muscle myopathy, I've had to learn how to walk again 4 times. I know Lindsay knows about this too with me, but has there been any links found with the liver and the muscle?
Yeah, I could take this, Nicole. Thanks for sharing. If you're talking about alcohol specifically, there's definitely a link. There is a condition known as alcohol-associated myositis.
Myositis, okay.
Which is a inflammatory response related to alcohol that it's sort of mysterious, just like the alcohol neuropathy is as well. But I would say it's not that common, but when it happens, it's quite debilitating. Patients basically have a really intense inflammation of their proximal muscles. So these are things like your buttocks and your hips and things you don't think about particularly when you're younger, but these are crucial big muscle groups that are important for daily function, and so and really there is no treatment for it except for time away from alcohol, abstinence, and this is where kind of loosely and indirectly answering the previous question about nutrition is important. Obviously replacing thiamine, that's, really important. Thiamine, folate, because when you're drinking alcohol, there's a lot of empty calories there, that need to be replaced with healthy calories from a variety of foods. And so nutrition is absolutely crucial to regain that. The prognosis is sort of uncertain and it's quite variable depending on, how old a patient is, how long they've been drinking, how much, genetic factors as well, So now, if you're asking about the liver specifically, that's much more complicated and very specific to your case, especially if you just had a transplant, and that's sort of a different story, and there may be other factors involved. But specific to alcohol, there is this myositis. So there is a link there, as you're suggesting.
Okay, thank you.
May I ask how long that can last, or like after you quit drinking, when someone would start feeling better?
With the neuropathy or with the myopathy?
The myopathy.
I'm sorry, Dr. M. What did you call it? Myositis?
Yeah, I mean, myopathy is correct as well, but yes,
Okay.
it's a muscle disorder or inflammation. I mean, I'm curious to see what the other providers have to say if they've seen this frequently. But usually it can take weeks to months for it to come back. Oftentimes I see it in patients with cirrhosis, more advanced liver disease. And so there's also, frailty and weakness of the skeletal muscle in general from cirrhosis too. So they're kind of mixed. And so it becomes difficult to really give you a straight answer. But the answer is not right away. It's usually, months, even years before regaining function and lack of discomfort.
Thank you. Thank you so much. Does any other doctor want to add anything to that before we move on? I know there's a study going on right now too about scarpiopenia. And I know that that's pretty common in people with cirrhosis. I know I had scarpiopenia. My muscles were just wasting away because my nutrition was bad. So yeah. So yeah, and but I don't want to run out of time if somebody else has a question. I see Nikki does. So hey Nikki, what's your question? And you're on mute. Can you get it? I'm giving you an ask to unmute button. Can you press that? There
I think
you go.
I think I just figured it out. Thank you. Yeah, the discussion about balance and frailty, I guess, inspired me to turn on my camera and ask a question. I'm a care partner, and my loved one is going to be evaluated for transplant in a couple of weeks. And our number one concern is the frailty testing, primarily because now he has cirrhosis and he's had some weight loss and muscle wasting. But the biggest issue is he's also an amputee. So when we looked into, when we spoke to the team about how they test frailty, it, to be frank, seemed incredibly ableist. It was like, oh, you have to be able to stand up so many times. You have to be able to walk for 5 minutes, and you have to have balance. And we're like, he's an above knee amputee. He doesn't even use a prosthetic. He's in his wheelchair. These seem like impossible tasks. So I'm just curious if anyone, I haven't been able to find any information about any particular exceptions or other ways to test frailty for an amputee that doesn't require two legs.
I know that grip strength is a pretty sensitive measure of
Okay.
and there are studies, lots of studies that actually show that if you are frail up to a certain point, it can actually affect your survival. And we do know that muscle wasting, cirrhosis is a muscle wasting disease. It's why we tell people to, have a protein snack before they go to bed. Because when your metabolism is slow at night, that means you're not burning it up. So you're actually being able to use that, build back. I always try to tell people that nutrition is very important. And the other thing I think is that we don't involve physical therapy and physiatry, and those are the rehab docs, enough to help you guys back on your feet, literally.
Yeah.
So you can ask for that. You can ask for a physical therapy evaluation or a rehab doctor, if to even before transplant, as a way of getting ready for it and being hopefully more healthy afterward.
Okay. Thank you.
Yeah, of course.
Robert, it's interesting you mentioned that, because I just made an appointment for after 6 months of reevaluation with my physical therapist.
Hey, I see Tom has a question. I think he's had a question for a little bit. So sorry, Tom. I saw you there. Unmute yourself. So go ahead and ask your question.
Yeah, no, you're talk. I should be unmuted. Can you hear me?
Yep, you are. You are.
I haven't seen a lot of other treatment plans because I haven't been through this multiple times. But the one plan I'm going through, it does seem to use a lot of the the methods they're talking about. They're bringing in the liver doctors, the hematologists, all these different doctors, bringing them in, and they're collaborating, and that's all good. But what ends up happening is the patient ends up getting information from multiple sources that frequently doesn't agree, and it's very difficult to get anybody to kind of take the lead and provide what is the clear communication here from these guys. I've got one guy telling me I need to stay on a liter of water a day. I've got another guy saying I need to go on 2.5 liters of water a day. And depending on who I ask, I get a completely different answer. And they both have very good, valid reasons, but they don't seem to be able to coordinate between the two and come up with what do they want me to actually accomplish. And I'm just wondering if that's common in multidisciplinary care, that there's multiple people involved, but they don't coordinate their answers to the patient. Is this common, or am I just taking things out of context?
I can take this. Thanks, Tom, for the question. I think it's quite common, and I think it points to the fact that there's actually a subtle difference between the term multidisciplinary and interdisciplinary. And I was taught this by some of my psychiatry colleagues. They're often interchangeable, and we think of it that way. So I know, Jen, you've been using that term, and so this is not a slight to you, but again, I learned this recently too. Multidisciplinary is really, you have different disciplines that are commenting on your case and involved in your care. Whereas interdisciplinary is probably what you're looking for, in the sense that you have different doctors from different expertise trying to answer and address your concerns. But there is a collaboration where there's a discussion about concerns about, let's say, ascites or hyponatremia or whatever issue that is, being addressed related to your fluid status, and tailored to you. Those doctors from different expertise would then come up with a plan that makes sense for you in particular, right? And so that's where I think there is the difference here, and perhaps what you're not getting is different I guess perspectives, and sometimes there is no right answer, but I think there usually is a right answer when it comes to fluid intake for a patient that has cirrhosis, for example. And it is a kind of common clinical problem that arises, and one where sometimes different levels of experience can lead to different answers. So, for example, you kind of get the textbook answer from someone who maybe is a little less experienced, or who are not a hepatologist, for example, right? And then you have those who say, well, they are technically right, but I am the lead person in your care. You may have a little too many cooks in the kitchen per se, but you need to kind of identify the lead person to say, this person has the most experience and expertise in this particular area, and I'm really going to lean on them hardest to be able to give me the answer. And so sometimes, even as a patient, you have to try to advocate for yourself to say, listen, I'm getting all these answers. You seem to be the person that is driving this ship. I need a more definitive answer from you. And because I'm getting confused here. And that's kind of the approach I would take if I was in your situation.
Thank you.
Thanks for the clarification on that, Dr. M, too. And I can't believe it, but we are at time. And so, Beth, did you have closing words or one last question?
I just wanted to tell Tom that, something I coach my mentees to do is to keep a book, because especially if you're going in between to different kinds of doctors, for example, you're seeing a nephrologist and a hepatologist. It's very good to have a book there with your notes in it, so that if one doctor needs clarification, you have it there for them. It's just being your own advocate. So, take notes as you go from doctor to doctor, and you'll find that it it will be helpful.
Thanks, Beth. Yeah, thank you. That
Or
and notes
record
are-
it. Record it.
Yeah,
Just
record it. That's another, yeah, recording it is a good idea too. And these days you can get the information pretty quick. Well, goodness, time flew. We didn't even get to panel discussion because you guys all had such great questions, which is fine. I wanted to make sure that everybody here got to ask what they wanted to ask. I think that's most important here. So I really want to thank everybody for coming tonight, and I especially want to thank our panelists tonight, Dr. M, Dr. Suthat, Dr. Hawk, Dr. Weinreeb, soon to be Dr. Coraluzzi, Linda. And so thank you so much for all of your knowledge and just for everything that you do for us. You have really dedicated your life to some people that I know that need it and deserve it and are worth it. So all of you know that you are worth the care and that you guys are all, you're all not alone. So I put in the chat a couple surveys. So please take a look at those if you have the time. And then also I put in the buddy system link to join our buddy system if you haven't done so already, so that we can really join together in community. Did you guys have any parting words, doctors, before we go, Linda?
Should I mute?
No,
All right.
it was a great meeting, and I hope to see everybody again. Maybe I'll come speak at another.
Oh, absolutely. I hope to have each of these folks back individually so that we can really get them with some good questions too and share their knowledge, because I know they have a lot more that they would like to share with us. So thank you all.
I would like to say hello. I just want to say hello to Linda. I met you in San Diego. We were having like tea. I want to say hello to Linda.
Okay. Nancy says hello to Linda. Okay. Next meeting is July 10th. It's a support meeting, social support meeting. So we hope to see you all there. And thank you very much and have a wonderful evening. Thank you. Thank you. We'll see you soon.
Thank
Bye.
you. Bye-bye.
Thank you.
Bye.
Thanks so much.